Good afternoon, everybody. My name is Candace Coughlin. I'm the Education and Outreach Coordinator for the Centre for Living Organ Donation at UHN. I am a visitor on this land from Ireland and Scotland. I strive to deepen my own understanding of the local Indigenous communities through ongoing learning, such as the Sanya's cultural training, and I commit to reframing my responsibilities to the land and the community. The Centre for Living Organ Donation is the traditional territory of many nations, including the Mississaugas of the Credit, Anishinaabe, Chippewa, Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. We also acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaties signed with the multiple Mississaugas and Chippewa bands. This territory is covered by the Dish with One Spoon Wampum Belt Covenant, an agreement between the Anishinaabe and Haudenosaunee allied nations to peaceably share and care for the lands around the Great Lakes. We recognize and deeply appreciate the history and connection to the lands, the enduring presence and knowledge and philosophies of the Indigenous peoples living here today. We acknowledge the continuing accomplishments and contributions that people make in shaping and strengthening this community. We have a responsibility as to commit to acknowledging and understanding the history and current experience of First Nation, Inuit, Métis people, and for the understanding to inform the work we do at UHN, so that first we can stop perpetuating the damages of colonization, and second, to begin to repair them. Land acknowledgements are just one small step in doing this work. We're grateful for the opportunity to meet all of you here today, to reaffirm our commitment to make the promise and challenge of truth and reconciliation real in our communities, and to co-create, collaborate, respective paths together. As a remote team, we encourage our team members, clients, and partners to reflect on colonization and the enduring legacy and engage in reconciliation in a meaningful way. So thank you everyone for joining us. Today, our webinar is about Patient Partners' Journey with the Indigenous Peoples Engagement and Research Council. I am very grateful that Can-SOLVE and IPERC have decided to partner with the Centre for Living Organ Donation for this webinar, and very grateful to have Cathy Woods and Arlene Desjarlais here with us today. Cathy Woods is a proud member of Nak'achuwin First Nation in Northern West Ontario and resides in Treaty 1 territory in the homeland of the Métis Nation in Winnipeg, Manitoba. Cathy has been involved as a patient partner in Can-SOLVE CKD since the network's formation. She's a patient partner lead in the Kidney Check Research Project, which seeks to screen, triage, and treat Indigenous people living in rural and remote communities across Manitoba, Alberta, and British Columbia. Cathy also served as a founding co-chair of the Can-SOLVE CKD Patient Council and the Indigenous Peoples Engagement and Research Council. She continues to be a member of these committees, as well as many others within the network. Cathy views her journey of kidney disease as her chance to give back to her community and to those who assisted her in dealing with her disease. Thank you for joining us, Cathy. And Arlene Desjarlais is a Métis woman, Winnipeg, Manitoba. Arlene joined the Can-SOLVE CKD Network as a patient partner after the loss of her husband, Glenn, to chronic kidney disease in 2016. In her role as a patient partner, Arlene has participated in many research groups, such as the Indigenous Peoples Engagement Research Council, IPERC, the Kidney Pro Working Group, and the Knowledge Translation Community of Practice. Arlene has found purpose and passion in her role as a patient partner in research, and through her work, hopes to continue to advance knowledge and eventual cure for CKD. Thank you so much for joining us, both of you. And just a header, which I probably should have given everybody at the beginning. I am on the end of antibiotics from strep throat, so my apologies if I am cutting in and out. I'm doing my best to keep my voice here. But I'm going to pass it over to the two people who we want to hear from most today, Cathy and Arlene. Thank you so much, both of you, for joining us today and taking time out of your very busy schedules to educate and let us know a little bit more.
Hi, everyone. I'm so glad to be here today. My name is Cathy Woods. My traditional name is givelifeUHN, which means Circling Golden Eagle Woman. And I am a member of Nak'achuwin First Nation in Ontario, and I live in Winnipeg, Manitoba. I'm just going to share with you for a few minutes about my own journey with IPERC, talk about some roles and responsibilities of IPERC, and just kind of highlight some of the things that have been going on in the last couple of years. And that I'm a founding member of IPERC. I started my first meeting with some of the group people was in 2015, and Can-SOLVE was founded in 2016. Together with myself and Dr. Evan Adams. At the time, he was at First Nations Health Authority. We started, I always like to say that we started IPERC with like words on a page, and this massive mandate that we had to do. And so, you know, one of the first things we did was we met with people, and we met with researchers, Indigenous researchers and scholars and doctors and community people to ask them what would be most important as we started this journey. And so here we are. It's, for me, I've been involved for over 8 years, and we do tons of presentations. I just got back from Philadelphia, where I presented our IPERC paper that we have that's been accepted into the International Journal on Equity and Health. And I did a poster presentation at the American Society of Nephrologists in Philadelphia. And Arlene and I are going to present the same poster at locally here in Manitoba on Wednesday at Ungazaming, which is the First Nations Health Authority, Indigenous Health Authority. And so we're looking forward to doing that presentation. And so I'll just tell you briefly that I had kidney disease in 2010, 2011. I was aggressively treated with a lot of steroids and chemo meds, and my disease has gone away. And so I've been healthy for over 10 years. And to me, getting screened early is one of the reasons why I work on a screening project here in Manitoba and across Canada, is because I was screened early. At the time I was diagnosed, I had no symptoms. It was a routine physical. And so, like my bio says, it's my opportunity to give back to the community that supported me when I was sick. And I'll just leave it at that, because we have lots more to talk about, and pass it over to Arlene Desjarlais, my co-chair.
Well, hello there. My name is Arlene Desjarlais, and I was the caregiver to my late husband, Glenn, who passed away from CKD in 2016. And my reason for joining and being part of the Can-SOLVE network was to give back. When Glenn was on when we were on our journey of kidney disease, our care team here in Winnipeg took absolutely wonderful care of us. And I've always said, if it not for them, I would not have had 5 extra years with him, and they kept him alive and going. I joined the network in late 2017 and attended my first annual meeting in 2018 in Vancouver, and that was absolutely a life-changing experience for me. It was the only place that I actually felt I could be one with my grief, and I didn't have to put on a mask. When you lose somebody that you love very much to something like CKD, your world changes, and people in your world, as much as they love you and want to take care of you, you end up being their caretaker with their grief. And with Can-SOLVE, I was actually able just to be one with it. And that led to many, many different things for me. My goal ultimately for joining the network was always to make sure that Glenn was never going to be a statistic on a piece of paper, and that if I could share our journey with somebody, that this would prevent the outcome for them, perhaps with their journey, or at the very least, that they're going to find their voice. With that, I've been able to do many different things. I've been on many different projects. I'm now a co-chair of the Indigenous Peoples Research Council. Had you told me back in 2018 that would be the case, I probably would have laughed and said, no way, no how, because my first meeting, I actually hid in the background and said absolutely nothing at the meeting and had no idea why I was there. But since then, I've published a paper in a medical journal about Glenn and our experience with a doctor who will tell you today, because of our experience, changed him as a doctor. So for me, anytime I can do something like this today and talk about, you know, the importance of patient partners and helping us find our voices is incredible. Because when you do a presentation and it's a live one and you look at the people in the crowd, you absolutely know when you've reached somebody. A researcher will walk away. There's at least usually one in the crowd that will walk away with a completely different viewpoint of their research. We're not looked at as specimens in a beaker anymore. We're actually looked at as human beings, and that makes all the difference in the world. So with IPERC, I mean, it's definitely helped me find a voice, and I'm incredibly proud to be here, and I can't wait to share our journey and hope to inspire more people to join the network and find their voices like I did.
Thank you, Arlene. Just to let you know and to situate us, in 2016, these 5 networks were established: Can-SOLVE, the Child Bright Network, Diabetes Canada, Imagine, and the Chronic Pain Network. And these networks were established through the Strategy for Patient-Orientated Research. And so Can-SOLVE was established in 2017. And I just want to note that, you know, in terms of a lot of these things that we have published, I believe somewhere in the area of over 45 papers that we've been part of, not just us as the whole Can-SOLVE network, and that in the papers that we've published. And that. So next screen. The Can-SOLVE network is a national network. As you can see, this picture was taken, I believe, in 2018, or maybe that's the 2017. It's a national network that brings together kidney patients, researchers, healthcare providers, policymakers, and caregivers. And for us, caregivers are often overlooked. They're always seem to be more interested in the patients. But when one person in the family has Can-SOLVE, it's a journey for the whole family. And so that's why we've involved. And we've also involved donors, those who are donors because of their journey. So it's really important for us that we have everyone involved in the decisions that are going to be made within the Can-SOLVE network. Next screen.
The Indigenous Peoples Engagement Research Council. I remember this as being a very clear memory for me of my first real actual engagement at a meeting. So IPERC consists of 20 individuals engaged across Canada. We have Indigenous patients, caregivers, researchers, practitioners, community leaders, and knowledge keepers within our group. Next slide. IPERC, the Indigenous Peoples Engagement Research Council, plays a very valuable role in providing governance and oversight within the entire network, the Can-SOLVE network. IPERC, we exist to ensure the Indigenous voices are heard and to help guide the research priorities that affect Indigenous communities and individuals with kidney disease. To support our mission, IPERC members are actively oversee the network's research projects, as well as the development of training materials and other initiatives. IPERC is leading a range of activities that support research and patient partners and to become more aware of racial biases, Indigenous voices and stories, the impact of colonization on Indigenous health and cultural safety and health research practices. You know, within this committee, we've managed to really change the landscape of how research is done within our own communities. We've been marginalized for so long, but now with IPERC and the way the network is structured itself, we absolutely have our voices heard, not only within the IPERC committee, but throughout the entire network. And we are actually people come to us looking for guidance and how to deal with certain things and how they can partner with us. And the next slide, please. We have the knowledge keepers in research projects that have come to life. There's a storytelling module that's come out with how we develop and we use our resources. It's just been, you know, it says here supporting Indigenous perspectives in research and respectful partnerships with Indigenous peoples and communities. That seems like a very small statement, but it's actually a very large one when you think of how our country is continuing to heal and moving forward. And this has become a bigger and bigger thing where we are really trying hard to make our voices heard at the table, and we're helping our own people within. But by doing that, we're strengthening them to go out into into the community and into the world and saying, you know what, you cannot speak for us anymore. We can speak for ourselves. So, you know, this has been the developing of resources and relationships to support cultural competency and safe engagement with Indigenous communities has been a very big thing. And we've come a long way since I first joined the network. I mean, something as simple as a land acknowledgement did not happen in the beginning. And now every single meeting starts with one. That just shows what type of leaders that we are. And we're showing the world who we really are. Next slide. Part of our 6 core values within IPERC, we talk about respect, reciprocity, relevance, responsibility, relationships, and everything is real. All the things that truth and reconciliation are working towards. Our work supports the TRC's calls to action related to health. Like, we acknowledge the impact of historical traumas on the Indigenous health of Indigenous peoples. We are working to close the gaps in health outcomes between the Indigenous and non-Indigenous communities. We have an ongoing cultural competency training for research team members to cultivate more cultural safety and humanity. Next slide. Okay, I think this is you. You're muted.
Yeah, I just wanted to talk about, you know, Arlene talked about the TRC recommendations that we use, and we use these recommendations. We actually put them into the grant proposal. We put in TRC 18, 19, and 24. And we also put in the OCAP regulations, and we also put in TPC 9, which talks about working with Indigenous communities, and Article 23. And Article 23 says Indigenous people have the right to determine and develop priorities and strategies for exercising their own right to development. In particular, Indigenous people have the right to be actively involved in developing, in determining health, housing, and other economic and social programs affecting them, and as far as possible to administer such programs through our own institutions. And so that's what we felt, that this was really important as a group, and that was the contribution that we made to the grant, was ensuring that these recommendations and all of these things were going to be in the grant, and they're also in our terms of reference. And I also just wanted to talk very briefly about the fact that we also have brought ceremony to our Can-SOLVE network. We always, whenever we gather as a group, we always contact Indigenous folks within the area where we're meeting and have some sort of ceremony to be able to be welcome to the community and for them to be actively involved in our network. And that is one of the things I can honestly say that, you know, in terms of what we do as IPERC, that we've had a really, I guess to say big would be not quite appropriate. We've had an overwhelming effect in everything that we do as a network, and to be able to do this in a good way is something that we as the Indigenous Peoples Engagement Research Council are very proud of. Next slide, please. And that's Arlene.
Yeah, like we say, we're generating knowledge. So Cathy just spoke about how we've introduced ceremonies into everything that we do. The other big thing that within IPERC that we have done is we've very distinctly speak very loudly about how there are 3 distinct communities within the Indigenous community there is the Métis, there's the First Nation, and the Inuit. Through IPERC, we speak very loudly about that. So that speaks to how we're generating knowledge. I don't think the average person knows that there are 3 distinct communities within our country of Indigenous people. It's an umbrella term, but through generating knowledge like we are, we're helping people. So that leads to all kinds of different things. Like we're working on early diagnosis, better treatments, innovative treatments. You know, it's all part of the things that are doing. So in phase 1, there was 27 projects. In phase 2, there's 9. So that's been toned, like it's come down a little bit, but the 9 projects from phase 1 will focus on sustaining, scaling up, and spreading knowledge of their research across Canada. The goal is to use this knowledge to improve patient care by applying its practices. Our goal is to change the culture of research to mobilize new findings. So knowledge is a very big word, and we are using the knowledge and we're using teachings throughout everything that we do. So as much as we're teaching, we're also being taught. So it's a reciprocal kind of relationship that we have with everybody. You know, it's just, it seems like it's a new thing, but it's really not. It's just now we're being heard a little louder. In Canada, you know, 1 in 10 Canadians has kidney problems. 1 in 10. When you think about it, you sit in a room with 10 people, 1 of the 10 of us is going to have kidney problems. But the more shocking thing is that almost 1 in 3 First Nation adults have kidney problems. 1 in 3. You think about that, that's kind of mind-blowing. Like, how is that possible? Diabetes and high blood pressure are the leading causes of kidney disease in our population. Why? Well, that's why we're here. That's why the research projects are going the way they are. We want to know why, but to know why, you have to know how to work with us. And if you don't know how to work with us, you need to learn from us, to learn how to talk to us, to get the information that you're needing, because the standard approach in the non-Indigenous community is completely different than it would be in the Indigenous community. It's about trust. And increasing rates of kidney failure and the use of dialysis over the last 20 years is astonishing, is absolutely astonishing. You know, even the mindset within in the Indigenous community, especially here in Manitoba and the northern communities. You know, I remember hearing Dr. Barry LaValle talking about how people going on dialysis up north is just an everyday thing. It's like, yeah, I have to go on dialysis. I just have to go 2 communities over. It was almost like it was an expectation within their own lives that, yeah, you know, at some point I know I'm going to need it. Oh, I'm just going to need to go 2 communities over. Where with my personal experience with my husband, Glenn, it was absolutely life-shattering. We thought we had to live our lives in a matter of minutes. Felt like your whole life was being condensed because you were now going to have to go in center to do dialysis. It's just very, very astonishing, the disconnect between the two, but to know and to find out that 1 in 3 of us are going to suffer from that is just absolutely, I have no words to speak to it. It's just absolutely shocking, and it makes me even more determined to make a difference and try and help educate and try to get the word out there about research and, you know, taking care of yourself and, you know, doing the things that you need to do, but most being an advocate for yourself.
I'm going to talk very briefly about the Kidney Check project. This is a kidney check project that started out of Seven Oaks Hospital in the center for their research center there, and it's based on it's called the Finnish project, a project that went into communities and did point of care testing. And so right now this project has reached to BC, Alberta, Saskatchewan, in Manitoba. Those numbers are 300 plus. We know that number is actually more. And what we do is we work with the community. We go into communities. We don't go into communities until we're asked to come in. Usually the first strategy is to start an awareness program and to send a letter to Chief and Council and the health director, and to be able to start that process. And we look at a strategy for authentic community engagement. We don't want to go into community and tell people how to eat and how to live their lives. We want to work specifically with the community on how they can improve their lives, and that through things like medicine changes, lifestyle changes in terms of some exercise and other things. And so the future direction of this project is to integrate this program so it's part of the provincial health system. Now it's part of public health. We're looking at Indigenous coaches and working with the community to mobilize the knowledge within the communities about kidney disease. We're also looking at the evaluation to understand Indigenous people's experience and those living with CKD and how we can improve it. We've had many papers published through this, and we continue to work with the communities in Manitoba. We're working on a virtual project because of Can-SOLVE. We had to pivot to a virtual project because we weren't able to go to the communities. And something like early screening really means a lot to be able to provide. Once we do the testing, they come out with a low, medium, or high risk. A low, medium risk, you have a set time that you're going to see a doctor, whether it's your primary care physician, and to work with the community and work with a community health representative on improving your health. And with high screening, they get to see a nephrologist within a reasonable time frame and to start that process. We're also doing a lot of awareness around kidney disease because, like Arlene said, people don't realize. One of the statistics I found out through my journey is the fact that in a large number of cases, 80% of the damage done to your kidneys is done before you even realize that you have kidney disease. So there's many things that can be done. And as someone who was diagnosed with kidney disease when I had no symptoms, I'm all too aware of the fact that your kidneys can fail without you even knowing that you have the disease, and you need to know what to watch for and to how to properly care for your kidneys. Next.
So this next project is Mind the Gap. This project came out of a project called III, whose goal initially was to improve information, the interaction, the individualization of care. So the outcomes, the project was to address one of the top 10 challenges, and identifying III was the mental health portion of it, and support people receiving hemodialysis. Bringing multiple providers such as cardiologists, diabetes care specialists into hemo units to improve the quality of care between the healthcare and the providers. So that turned into Mind the Gap, and which I'm part of also. I was on III and Mind the Gap. I'm on Mind the Gap. Its future direction aims to help improve the experience of mental health of individuals receiving dialysis, guided by patient partners, including collaboration with Indigenous patient partners to ensure that a project is culturally sensitive and aligns with Indigenous ways of knowing, being, and healing. So when you think about people being in dialysis, it's not a small thing. There's many things, especially in the Indigenous community, that prevents people from going and seeking out their treatments. It could be anything from them not having a ride to their mental health issues. There's all kinds of different things that come with it. So this project is trying to mind the gap. It's trying to close the gap and get more people to start taking better care of themselves, start attending their dialysis treatments, and to really figure out where the issues lie, so that perhaps the healthcare system themselves can change directions and try and address these reasons why people don't come to treatment, instead of just saying, well, they're non-compliant, we can't help them anyway, so we'll just move on to the next patient, which is in some cases does happen. People will, you talk to a provider, like a clinician or a nurse, they'll just say, well, they're just not attending, they're non-compliant, but no one stops to ask why. Like, why is this patient not coming to dialysis? What's the issue? Like, is there a greater issue that we need to address? So with this project, it's really going to try and identify those things and really start to get the right components of care included in everyday dialysis, your dialysis journey. I mean, because it really is a journey. Everybody's journey is different, but there are some things that are sort of consistent that at one time or another people do experience. So with this project, they're really trying to do it right, and they're trying to really be culturally safe and sound and do what needs to be done in the project.
And next, we're going to talk about the iCare project. The iCare project is headed out of the Health Science Center and Dr. Allison Dart. who's actually on our IPERC committee, is one of the principal investigators on this project. And the eye care research team was created the estimated glomerular filtration rate, the EGFR, which is a relatable tool to estimate kidney function specifically in youth and with type 2 diabetes. Many of the youth with type 2 diabetes are at risk of developing kidney disease with the potential of experiencing kidney failure later in life. The future direction of the program will allow care providers to more accurately monitor disease progression, guide prevention and strategies for youth living with type 2 diabetes, and partnering with research groups internationally to validate the tool with 2 additional populations of youth with type 2 diabetes in the US and Australia. And one of the things about the eye care project was that within the finished project, the precursor to Kidney Check project, we did go into schools, and we were alarmed at the number of children that had high blood pressure, that had diabetes, that had type 2 diabetes. And so this project was kind of born out of that, to be able to have strategies and work specifically with a lot of the northern communities, and bringing the communities and their caregivers into Manitoba to talk about how we can provide better service to the youth, because most of the services that are out there are geared for adults. And so this project is really, really important to be able to have access and have some meaning for those with type 2 diabetes. Next slide. And so, you know, this is the 4 pillars of phase 2. In phase 1 of Can-SOLVE, one of our favorite things that we used to like to say about it was that the right people get the right treatment at the right time. And so phase 2 is more about the knowledge mobilization. And I can honestly say that within all of these 4 pillars, that IPERC is using all of these and has used, and it's a foundation of how we work. And so these 4 pillars just naturally flowed for us, because, you know, we do the enhancing Indigenous cultural competency within research. I have had many conversations with the researchers about how to properly work with their communities in terms of protocol, in terms of contacts, in terms of all different sorts of things. Advancing principles of equity, diversity, inclusion, and accessibility within all of the research projects. Knowledge mobilization is something that we're really working on. It's not only just about publishing the papers, but it's also about if a new study finds something that really works, to be able to get that knowledge to the community and to get that knowledge out there. And certainly within Can-SOLVE and IPERC specifically, we work on capacity building and partnerships. Within Manitoba, we partner with the First Nations Health and Social Secretariat. We also, within other provinces, they partner with First Nations health authorities, the same thing in Alberta and the same thing in Saskatchewan, working with communities and working with Indigenous health authorities and health partners is something that's very important. And it's doing the work with communities is something else that's very important. So when these 4 pillars came out, you know, like I say, we were already doing a lot of this stuff, so it was just a natural fit as we move into phase 2. Next screen. And one of the things I too, like Arlene, have learned how to be a voice within research. I wish that I would have kept track of how many times I've presented or done videos. Arlene and I like to say that we very seldom say no to any opportunity that we have to be a voice out there. And IPERC and Can-SOLVE have trained me through their storytelling module, through all of our training and all of our ceremonies and things that we do on how to be a voice within researchers. I'm not afraid or intimidated to use my voice, whether it's with a researcher or a patient, to be able to help them to understand how you too can be a voice within research. And one of the things about patient-oriented research is that it has proven to be, research has proven to be more valid and more better outcomes for those people when we have patients involved in the research. And then I'll pass it off to Arlene for some finishing statements.
How to be a voice in research. I didn't know I could be a voice in research until I actually sat down and did the storytelling module. Because up until then, I didn't know I had a voice and I didn't know I had a story. So that led to many different things. After literally the pen being held virtually to make me write a story, I wrote it and it has completely changed the landscape of my life. What I always say is had I not joined the Can-SOLVE Network and did the storytelling module and become a part of all of these research projects, I truly don't know where my grief would be today. This has helped. It'll never ease the loss that I suffered, but it definitely has helped transition things in a very good way, where the things that happened to us during our journey, I'm now seeing things change. So although it was 10 years ago, we were going through this almost, more than that, more than 10 years, I can see that the things that we were struggling with back then are now being addressed now. And that's huge. And to know that I'm just a teeny tiny part of that is, that gives me more satisfaction than I can tell you, to know that the voice that I didn't think I had is now being heard. Incredible. I mean, you can't do research about us without us. And us is everybody. It doesn't matter if you're brown, white, or orange, or purple. Research doesn't happen unless it's a collaborative type of thing. We have as much to give as everyday, ordinary individuals, as a scientist, a doctor. What I say in our meetings all the time is, at the end of the day, we are all just ordinary people doing extraordinary work. So that's right from someone like me, right up to the most highly educated person. We are just ordinary, everyday people trying to change the world of someone suffering with a disease like this, kidney disease. It's not just kidney disease, it's any disease out there. So, if you think you're not making a difference, you are. You just need to keep talking and you'll find your place. You'll find what is important to you to get into a research project for. And truly, the researchers want you to be there. They want you to be part of their projects. They can't do the work without us. Again, you can't do it without us, and we can't do it without them. So we're changing the world. We might not see it today, but someday we'll see a switch. Our kids will see that, hey, you were part of that. You helped change the world. You helped change the landscape of a disease like kidney disease in a small way. Why wouldn't you want to be part of something like that? That's what I always hold on to. Oh, how do you join IPERC? Well, we have this lovely coordinator named Jocelyn. She would absolutely love to hear from you. If you want to join us, the Indigenous Peoples Engagement Research Council serves to guide the conduct of the network's activities and accounting for the unique aspects of patient-oriented research involving First Nations, Inuit, and Métis people. Using an ethical framework that encompasses the principles of ownership, control, and access, the OCAP, and the elements of participating research, IPERC's mandate is to ensure that Can-SOLVE CKD appropriately incorporates, addresses aspects of the unique needs of the perspectives of Indigenous peoples. Members of the council include patients, families, caregivers, knowledge keepers, and healthcare professionals, and federal and provincial decision makers. To get involved, you need to contact Jocelyn Jones at jjones@Can-SOLVE CKD. She'd love to hear from you. We're looking always to grow our group and find different voices out there that that need to be heard.
Amazing. Wow. Thank you so much, Cathy and Arlene, for that overview of all of the incredible work that's done across the country and the fantastic work and how to get involved as well. So I'm going to open it up now to anybody out there who has a question for Arlene, for Cathy, for Jocelyn. And if nobody has a question, I've been scribbling down a lot of them for you as well.
Thank you so much. That was absolutely fantastic discussion and very timely for my work. Probably many of you know the National Kidney Foundation is working on a national CKD framework as well. And one of the topics that I'm actually starting to work in is focus groups, specifically one in Indigenous health, and ensuring that the unique perspectives, but also even, rural, urban challenges and things like that are incorporated into this overall framework. So I think other than always going to the one person that we know that, can kind of be your gateway in there, are there ways that you suggest, Arlene and Cathy, for someone like myself, someone who looks like myself, to be able to wholeheartedly not just solicit but engage people? I think, Arlene, you made a statement that absolutely resonated with the conversation we were having last week, which is, we're going to be having some focus groups, and they're going to be 90 minutes, and they're going to have questions that look like this, and then the next topic of discussion was, but that may not fit the focus group we want to do in Indigenous engagement because of the trust-based requirement and need for relationship and things like that ahead of time. So just any thoughts you have on how to approach and get that kind of a conversation started. We do have people like Vanessa Tate and others that that are helping us along the way as well, but because she's actually one of the co-chairs of this initiative. But
Sean, I think there's a couple of ways that you can we could be involved. Is within your strategy is that one is that we could send out a request actually from Can-SOLVE and from IPERC about being involved in this. And the other way that I'm thinking, which is a bit more probably hands-on, is, perhaps if you sent something to Jocelyn and Arlene and I as co-chairs could consider having a meeting with the members of Can-SOLVE to be able to do it. And actually have a brainstorming session within Can-SOLVE about ways that we could be part of those. And, certainly even one of the ways that we could help too is with Jocelyn's assistance is we could look at the questions and make sure the questions are I don't want to say appropriate, but the questions that you'll get meaningful answers to them. And certainly I think Arlene and I and Jocelyn would entertain doing something like that.
Absolutely.
that's fantastic.
It's more how the questions are asked and written. It's more of a come at you kind of thing, the backs will go up and you won't get any kind of feedback because they don't know. It's a general mistrust, just based on cultural history. But like Cathy,
for sure.
We're absolutely open to any kind of assistance that we can get. I mean, again, you can't do research without us, without us. So,
Yeah, the other part that really resonated, Cathy, from your story was the whole premise of prevention and what that meant for you, and heading off your journey in kidney health, and I think that keeps coming back in all of the work that we're doing, is how do we better incorporate prevention and early intervention, and I love seeing a couple of your topics there. We're dedicated to early folks early on in their diabetes or hypertension journey, so hopefully they don't ever need the services some of us have required.
That's why we feel it's really important to make it part of public health, because they do kidney screening, women get notices about, mammograms and other tests and that. And so, we really believe firmly that, to get your kidneys screened and to have the right tests done by your primary care physician. I mean, I was just really lucky that had a primary care physician that did regular blood tests and urinalysis. And when I first found out I had kidney disease, a couple of my colleagues at work had just had physicals. And so I said, well, did you get a urine test? And they didn't get a urine test. And so both of them went back and asked for a urine test, and one of them had indications of kidney disease. And so, to be able to do that and to be able, and I think it's even more important in this day and age in terms of healthcare, because, it's a proven statistic, as you probably know, Sean, about early intervention and the delay of dialysis and the delay, all of those things, to be able to have a change in lifestyle or even a medical, to get high blood pressure medication, to be able to do something as simple as that, and to be able to have access and care. And a lot of times one of the issues is for people that we find when we go to communities is, I've had the same primary care physician for over 30 years. I'm getting a little scared because he's getting to look quite gray, and I'm thinking, I've had him for 30 years. Like, what am I going to do when he retires? And my daughter just recently struggled with their primary care physician retiring, and she spent 2 years of ill health, with showing up in emergency rooms. And so that's what ends up happening. So, early testing is so important. That awareness part, of letting people know about their kidneys is so very important. It just kind of sneaks up on you. If you would have told me I was absolutely gobsmacked when I found out I had kidney disease. I was mad. I had no symptoms. I'd had one of the best years of my life, and things were just like sailing. And then right away it was like full stop on everything, and I had at that point got yearly tests. So certainly awareness is something that's really important. My kidneys, my health, we have a lot of different awarenesses, and I'll let Arlene finish.
I agree with what Cathy said. I mean, at the end of the day, I think what we really need to educate people on is similar to getting a cancer diagnosis. Told you have diabetes and high blood pressure could lead to kidney disease. That needs to be the same type of reaction that you get. I can speak personally from my experience with my husband. He was diagnosed with type 2 diabetes in 1995. He did not take that seriously until 2010, when he was told he was no longer going to be monitored. He was going to be full on training to do dialysis and kidney transplant. That's when the realization of what his lack of concern over the last 15 years led to. Had he been told in 95 that this was similar to a cancer diagnosis, we would have hit the ground running and did everything possible to avoid the outcome that he had. So, I mean, getting tested, but people need to know the impact of the choices they're making, because it is a silent killer. You don't know you have it until it's almost too late. So, I mean, but everything Cathy says, I completely agree with. People have no idea how important it is.
I'm wondering too if the two of you have any insight or thoughts. We talk a lot about the power of peer support and connection. I'm wondering if there's somebody who's recently diagnosed with kidney disease and feeling lonely or overwhelmed, like the feelings you've talked about, Arlene, and those of us who have kidney disease know all too well. With that, the research program about mental health support, but also within IPERC and within Can-SOLVE, are there places as providers and people within the healthcare world that we could refer to if somebody was feeling lonely or in need of support? Is there somewhere within IPERC or within Can-SOLVE that, even if it is not formalized, that somebody may be able to reach out to?
think generally as a rule, I don't know, Cathy, you could probably speak to, is when we know that somebody is recently diagnosed, is somehow they manage to find their way to us. And I've always said, for me personally, like when we were going through our journey, patients talking to patients is a completely different thing than a clinician talking to a patient. They hear what the doctor says in doctor terms. But if I were to sit down and talk to Cathy and say, okay, this is what he told me, blah, 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 blah. And she turned around and said, okay, well, this is what happened to me. And this is what they're going to tell you, and talk to me like in terms that I could understand, would have completely changed the landscape of what we were going through in the moment. You know, I know that I've talked to several patients where they've just been resistant to going on dialysis and didn't want to do this and didn't want to do that. But after having spoken to me through the clinic in Winnipeg that we were a part of, it was like, oh, okay, well, oh, I didn't know that. Oh, okay, well, that seems a little bit more manageable. Patients talking to patients is, I think, the link that's missing in the clinics all the time. Like if you were able to sit down and talk just to an ordinary everyday person and know what that impact is going to have on their everyday life because of what you went through, I think that would change the landscape of some people's worlds. Not everybody would change, but I think people would be impacted enough to know, like, okay, this is scary, but I can manage this. And I have someone I can go and say, okay, well, did this happen to you? Yeah, okay, this happened to me, and this is what you can kind of expect. I'm not an expert in it. I just know what we lived through.
Mm-hmm. And I also think too that, you know, we have a lot of resources on our website in terms of My Kidneys, My Health. We have our kidney link. Our kidney link is really good for those who are interested in research. We regularly send out information to people about projects that are looking for people to be involved in. And even if it's just ask a question, do that kind of thing. And, you know, I'll say like Arlene, like I've gotten many calls and many emails from people saying, you know, my sister just got diagnosed. Can they talk to you? And I do it all the time. And I also know that within BC that there's the Kidney Friend Circle, and I think, like, I'm a member of that, and I think that's just a great resource, because I'll tell you, when I first got kidney disease, I did not go on any website other than one that my doctor referred me to, because there's so much misinformation out there that I was kind of afraid to do that. So I just, and some of it was really kind of scary, so I didn't do a lot of my own research. I just went with what my doctor said until I found out more, and until I decided to get involved in Can-SOLVE. So I just thought it was really important. You know, certainly within Can-SOLVE, we've got a lot of resources. We've got a lot of people. I see Charles there, and so we've got a lot of people. You know, the Transplant Ambassador Program, of which Charles, and like, it's just so amazing to be able to do those things and that. So, you know, we're very approachable. You know, if we very seldom say no, and if we can help you, we can find someone to help you.
Beautiful. So I'll send it out for one final question before we say goodbye, if anybody has any more questions. Okay. And it was nice to see your friendly faces, Sean and Charles and Claudia. Thank you so much for joining today. We will be putting this on YouTube so many people can have access to this amazing information today that you, Cathy and Arlene, have presented. Thank you, Jocelyn, also for collaborating and getting this really important information out there. I will also follow up. So in the link that people will be watching, we can have links to other places that people can go so they can check out the research projects that you've talked about today, and any further information that they may be interested in. So thank you so much to everyone, and thank you again, Arlene and Cathy. It's always a great pleasure to get to hear from you.